everyone. This is Rachel here at the OBL and ASC Marketing Blueprint hosted by Patient Pro Marketing. Today we're talking about two conditions that millions of people deal with, but most people don't want to talk about: enlarged prostates and hemorrhoids. What's even more surprising is how many patients are told just to deal with it or jump straight to a major surgery, without even hearing that there are many less invasive options. Joining me today is Dr. Adam Gropper, an interventional radiologist who is helping change the narrative through embolization procedures that are truly transforming patient care. Dr. Gropper, I'm really excited to have you here. Let's start with your story first. What led you into interventional radiology?
Hey Rachel, thanks for having me. Well, that's kind of there's a long answer and a short answer to that question, but I didn't go to medical school immediately after college. I actually did software engineering, and so I've always been kind of a techie. I worked for General Dynamics back in the 80s, and after a few years of that, I decided I really wasn't cut out for that kind of life, and I spent a year or so trying to figure out what I wanted to do and ended up deciding on medicine. And my fourth year of medical school, I'm doing a radiology elective, and this guy walks into the room. I think it was the last day of the elective, actually. He walks in with a box of balloons and catheters and stents and all this stuff. And I'm like,
Boys.
that's what I want to do. So, so I've been doing it ever since.
That's awesome. And
Yeah.
can you tell everyone where's your practice at?
So we're located in Miami. We have three locations, one in Kendall, one in the Aventura, North Miami area, and one in Broward, actually, so close to Fort Lauderdale, Hollywood area.
Okay, and Vivid Vascular, did you start as a vein practice and then expand into more procedures?
Yes. So I started doing veins in an office setting about 15, 16 years ago. Did that for 6, 7 years, and then started getting interested in the whole idea of an OBL, an office-based lab, and started looking into it. Got went ahead and bought a system and started out just doing intravascular ultrasounds and iliac stenting, and then gradually moved into more exotic stuff like the embolizations.
Yeah. So speaking of exotic, what about enlarged prostates and hemorrhoids piqued your interest? Because I know we've had conversations how you love doing these procedures.
Yeah, well, they're I think they're really cool procedures from both patient and doctor standpoint. For me, it was a challenge, picking up on doing them. I had to do quite a bit of training and a lot of cases proctored before I was ready to do either of them on my own. So it was a great learning experience for me. It was not really so much that it was a new skill, but it was refining skills that I'd been using all along. It's challenging from a technical perspective at first, and then you're as good as you get, as experienced as you get, you still learn something on almost every case. So I really like that part of it. But what's really great about it is from a patient perspective, these procedures are so easy on the patient. They're easy from a stress standpoint. Uh, they they're super comfortable. There's very little in the way of recovery period, and they get these amazing results without much risk. And so for me personally, like the measure of a great procedure is when you've got something that works well, it's high benefit, low risk, and so I'm just like a total believer in these procedures.
Yeah. So speaking of that, let's talk prostates, right? We know that's the traditional surgical treatment for BPH is much more invasive invasive, right? Like it's
Yeah.
scary. So
Yeah.
let's talk about the difference between a PAE procedure, prostate artery embolization, versus traditional.
Yeah. So when I sit down with a patient, I basically tell them that there's basically four ways to treat urinary tract issues from benign prostatic hyperplasia. One is medication. So most people try medication before they have any sort of procedure. But generally, medication is a band-aid to the problem. It can help, but it rarely gets rid of all the symptoms, and over time, the prostate generally keeps growing. And then at the other end of the spectrum is actual surgery, which generally is reserved for prostate cancer or very extreme cases of BPH. So that leaves two in the middle, which are the interventional radiology procedure, the prostate artery embolization, and the urologic minimally invasive procedures, which are things like the TURP, the transurethral prostatectomy, the aquablation, the Resume, um, the green light laser, and there's I think there's like 15 of them now or something. It's hard to keep track of them all.
I
But
heard they
really,
use words like shave, freeze,
yeah,
cut,
rotor.
rotor. Yeah, and I used to work in urology. I worked in urology for 6 years. I've seen patients post-op come in, and I would never have that as a first option for my dad or my husband
Y-
if he ever needed this.
Yeah.
Sure.
Yeah, I mean their build is minimally invasive, but they're pretty invasive for minimally invasive procedure. And
Mhm.
I think, look, all the most of these procedures do have a place in prostate care, but I think it's about the safest place for most patients to start. If you're having a problem with the engine in your car, you don't jump right to overhaul. You try the small stuff first to see if that fixes it. And so this shouldn't be any different. I think that the problem with the urologic procedures, this is one of the things that I explain to patients when I first meet them, is that they're all basically the same, whether they're using, steam or water pressure or a hot wire like with the TURP or laser energy. They're all removing tissue around the urethra, and that can damage nerves and also damage the sphincter that controls urinary continence. It damages the ducts through the prostate, uh, that are coming from the seminal vesicles, and these types of interventions can lead to erectile dysfunction. Some studies say as many as 15% of patients that have these procedures have irreversible erectile dysfunction. 1 to 2% can have urinary incontinence, and a lot of them have, uh, I mean, more than 50% have retrograde ejaculation or dry ejaculation, which some of them get better, some of them don't. And when patients start asking questions and hear this, they will often run from the urologist because these are not, if you're 85, maybe not so scary, but if you're 50, 55, um,
It's
these
young.
sound like pretty scary side effects.
Yeah.
So, so that's the problem with the minimally invasive procedures. And so when I then go on to explain prostate artery embolization, that, it's about an hour procedure. They don't have to have a urinary catheter. They certainly don't go home with one. They the recovery period is basically, maybe their urinary frequency or hesitancy or urgency is a little bit worse for a couple of days, but other than that, they don't notice any change. Um, the rate of side effects, complications is virtually zero for us. We don't see anything, maybe some bruising in the groin. Um, and after about 3 weeks, the prostate starts shrinking and they really see remarkable improvement in their urinary function
So
with almost no risk.
yeah, so you mentioned earlier that sometimes those other procedures are necessary. So who is your ideal candidate for prostate artery embolization?
Well, I mean, pretty much anyone uh, with lower urinary tract symptoms that are moderate or severe. Anybody with a prostate gland that's 45 grams or larger. We like them to have a normal PSA, although you can have a little bit increased PSA if you have a large prostate and it's still considered normal. This is rather than just looking at the PSA, we look at something called the PSA density, which is PSA adjusted for the size of the prostate. And assuming they have normal PSA and no urinary tract infection and a large enough prostate, that's a great candidate. We do prostates, I've done prostates that are well into the 200-gram range, and they do great also. But I think the sweet spot is kind of in the 50 to 100-gram gland size. We see, really remarkable, consistent results in that size range.
Okay. And then what you kind of already went into detail about the procedure itself. What how soon do most men start to feel better?
Yeah, it takes about 3 weeks, although sometimes they come in for their 1 week follow-up and they feel like it's already better, which usually is just because we put them on steroids and some other meds that helps them urinate better, but they're usually pretty happy at 1 week.
Yeah, that's awesome. And
Yeah.
then we get asked this question a lot, because we have some direct to patient ads out there for this, and men have asked, do I have to do it more than once?
Yeah, so that's something else I go into with the patients because, when you paint the picture that I just painted with the minimally invasive urologic procedures versus the PAE, you know, if you're really listening to it, my first question is, well, it kind of sounds too good to be true. What's the catch? Well, there's always a catch, right? In life, um, you rarely get something without giving something up. And with PAE, what you're giving up is the durability. So a PAE will generally last 8 to 10 years, whereas these more invasive urologic procedures will often last patients the rest of their lives. So that is a benefit to those procedures and a drawback with PAE. But with PAE, you can also repeat it. So sometimes, sometimes you can be successful repeating it, sometimes not. You often don't know until you try. But I encourage my patients to look at it as a bridge to the next thing because 8, 10 years from now, first of all, who knows what's going to happen tomorrow these days, but 8, 10 years from now, who knows what's going to be available, what new procedure will be available. So I think, looking at it in the intermediate term is a good way to go.
Yeah. And then
And you could, and look realistically, if it doesn't work or it doesn't last long, you can always have the more invasive procedure later. But start with the less invasive, lower risk procedure and go from there.
yeah, yeah, I like what you said and comparing it to an engine, right? You don't just go straight and say, "Give me a brand new engine." You figure it out little bits at a time.
Yeah.
So the number one question we get from men is how does PAE impact sexual function versus traditional surgery?
Yeah, I mean, compared to the other approaches, PAE uh, has virtually zero effect on sexual function. So, patients, I haven't personally had one, and there's very little in the literature to support any episodes of erectile dysfunction or even retrograde ejaculation in any sort of significant numbers after a PAE. So sexual function is unaffected by the procedure.
Yeah, I think that needs to be highlighted probably more in our ads too, because it does seem to come across as the number one concern.
Yeah.
Okay, so let's talk about hemorrhoids now. If you could explain, kind of like you did at the beginning with prostates, what is hemorrhoid embolization,
Yeah.
and who qualifies for that sort of procedure? Because I know that one's a little tricky.
Yeah. So hemorrhoid is a bit newer than prostate, and there are less of us that have done a lot of them out there. Um, but uh, but we have done a ton in South Florida, and we're seeing really great results. The landscape for hemorrhoid is a little different than prostate. The most most internists will usually uh, give patients creams and ointments to treat their hemorrhoids or recommend sitz baths. They very rarely will refer to a specialist for hemorrhoids. So it's kind of it's almost like varicose veins. It's like, well, it's one of the things you get and you kind of have to live with it, adjust your lifestyle. Even a lot of gastroenterologists don't seem to be that interested in treating hemorrhoids, which is interesting. I think there are gastroenterologists that like to do banding, which is one of the alternative procedures that we'll get to in a minute. But most of them just sort of see them and, they're more interested in finding colon cancers and more serious things. And, I get that. But hemorrhoids are really quality of life impacting
Yeah,
for patients. And so they,
uncomfortable and
yeah, yeah,
embarrassing, and I mean, it's hard to get people to even open up and talk about it. I feel like
yeah.
just being brushed off by specialists to
Yeah, I think that that's another obstruction is a lot of patients don't even want to talk about it with their doctor. But when they do, if they don't get, if the doctor isn't receptive and ready to offer some real treatments, then it's really disappointing for the patient. And so we do occasionally get some referrals from some of the GI doctors we get for the embolization procedure, which is nice. But beyond beyond embolization and banding and the topical treatments, which don't really do much, there's again surgery. The problem with surgery for hemorrhoids is it's like really difficult for the patient. It's like you can't sit down for 60 days after one of these procedures. And if you
six
have
zero 60.
60, yeah, like 2 months. And if you have a complication, uh, it can really be lifestyle disabling. So again, it's sort of the same thing. It's like surgery is only for very extreme cases when you've got no other alternative. The medications don't really do anything, so you're left with banding, which the GI doctors do, versus the embolization, which we do. Now, banding is a bit less invasive because all they do is they go in through the anus with a little scope and put a rubber band around a portion of the hemorrhoid. But the problem is it can be uncomfortable. A lot of patients report pain after having a band placed. And if you do the banding right, it usually takes a series of banding procedures to get the result. Um, so the the notion of sort of going through some pain and having to go back over and over again until the problem's resolved, a lot of patients don't like that. And so they come looking for a one and done procedure. And the hemorrhoid embolization is usually just a one-time procedure. And again, it's like the prostate procedure. It's painless. It takes about an hour. There's really no significant recovery downtime, just like same with prostate, a couple of days without lifting. The complications we see are related to the groin puncture, so sometimes some bruising, but um, but that's about it. And when you compare banding to the hemorrhoid embolization, they both have about an 85% success rate. So we work with gastroenterologists, and when somebody fails banding, they'll often get sent to us. When somebody fails the hemorrhoid embolization, we'll often send them for banding, and usually one of those things will work. The other thing about, and sorry if I keep going on, but
Oh, go. I've learned a
one
lot.
one of the things we see with patients a lot is um, that bowel habits are often one of the causes of the hemorrhoids getting worse and having flare-ups because of this.
Oh,
This,
the toilet and getting distracted on your phone.
this, and the toilet are really bad for hemorrhoids. You cannot sit on the toilet for 30, 45 minutes with your phone. You're going to get hemorrhoids. And especially if you tend towards constipation and straining. So we talk to patients about that first. And if a patient's just beginning to start to have some symptoms from hemorrhoids, we'll usually try to manage them with that and see if they'll get better just with conservative measures and changing their bowel habits. Um, and we'll wait on doing any sort of intervention until like it's clear that it's becoming a recurrent problem. And that seems to work well because some patients just need, a little help with, they start taking more fiber and stop sitting on the toilet so long they get better. A
Yeah.
lot of them get
It,
better.
it's
Yeah.
almost like you need a no cell phone in the bathroom sign, right? Like
Yeah, for
go
sure.
in there, do
Yeah.
your business and get out.
Yeah.
I've heard
And
that
it's like,
before, and I
yeah,
really never knew if it was true. I threaten my
yeah,
husband
there's
all the time, like,
no,
you better get off your phone.
yeah, no question about it. And it's funny because patients know it. We'll be like, so do you sit on the toilet for a long period of time? And they'll be like, no. And then I'll be like, do you take this in the bathroom? And then they'll smile. Like, they'll be like, okay.
You've talked about some of the risk and the outcomes, which I think is great. Recovery for both procedures sounds very similar, right? For prostate artery embolization and the hemorrhoids. So
Yes, it is.
here's my question for you, because you talked about the GIs, you talked about internal medicine, and even urologists. Why do you think that so many patients don't know that these options exist?
Yeah, well, that's a problem. I think you know, I hate to say anything negative about my colleagues in the other specialties, um but I think, people even doctors tend to talk about what they know best. They things like banding for hemorrhoids and all of these um, minimally invasive procedures for prostates. Um, you know, Doctors like to solve patients' problems, They don't really like to refer them out somewhere else. So I think that patients often don't get completely educated when they go to the specialist's office. As an interventional radiologist, we have a real um, identity problem with the public because, public, the average patient out there knows what a cardiologist is. It's a heart doctor, right? They know a urologist is a urology, urinary tract doctor, but interventional radiologist, what the hell's that? Nobody knows what they do.
Yeah.
Um, there's internists and lots of doctors out there that don't know what us interventional radiologists do. So for us to expect the public to be able to find us just is not reasonable.
So
And so,
you mentioned though that you and your GI local colleague send patients back and forth. How did you create a relationship like that?
well, Rachel, you gotta kiss a lot of frogs before you find a prince, That's the bottom line. There are doctors out there um, that are willing to work with you, but it's hard to find them.
Mhm.
And I think that sometimes doctors are afraid that we're gonna take all their patients, which of course is kind of silly because there's no way we could do that anyway. But you just gotta get out there, and we have, you know, we I have an on the ground marketer in my practice that actually visits both specialists and internists and sort of spreads the word about what we do. And I'll make calls when I see that a patient has found us themselves, and I can find out who their primary doctor is, or if they have a urologist specialist. I'll get on the phone and I'll call them, and I'll, sort of tell them what we're doing, that I'm seeing their patient. Sometimes they'll call the patient and say, "Don't do that." Sometimes they'll be receptive, and I think you just have to keep doing that, and eventually you're able to build some relationships.
Yeah. I think that's why that's why we got into digital marketing, right? Direct to patient education and awareness. Really, that's how I like to look at what we do. And I know you do a lot. It sounds like you have a clinical liaison, had boots on the ground, which is
Yeah.
awesome. I think every practice should have something like that. But you also are doing a lot of direct to patient marketing. Where do you right now, if you had to think about your hemorrhoid patients and prostates, where are you getting most of them? Is it from local referrals or from digital marketing?
Without a doubt, digital marketing is the major pipeline of patients into the practice. We it was interesting. We started doing online marketing with doing pay-per-click advertising, and which we still do. We saw a very large response to our advertising of hemorrhoids. Prostate, not so much, but hemorrhoids seem to be easy at first to get patients in the door. That's sort of dropped off now. I don't know if there's more competition online for those ads or not, but we still see a lot coming in. Believe it or not, we see a lot of patients that have a prostate embolization and then find out that we do hemorrhoids, and then they have hemorrhoid embolization. And also with uterine fibroids, a lot of patients that have uterine fibroids also have hemorrhoids. And so there's a lot of cross-pollination between different service lines, and also with our vein and vascular work, we see some of that. But by far, online is the place to go. And I think it's been great working with you guys, because the as well as the pay per click and the search engine optimization stuff has worked, going down the social media marketing road with you guys has increased our leads a lot. And so we see a lot more patients coming in for these procedures.
And when you see those patients, right, specifically ones that are targeted on social media or gone through your SEO search or your PPC, what are they like in the clinic versus someone that hasn't seen an ad or been educated or was just referred?
Yeah, so I think that with few exceptions, the and initially I was really skeptical about social media uh marketing patients, because like, they're scrolling through, and I don't know how many seconds you get with the average person on social media to make an impression, but it's not too
Dr.
many.
Gropper, they're
And
sitting on the toilet getting hemorrhoids.
that's right. Yeah. That's perfect for
They're
hemorrhoid,
on
I guess. Yeah.
social media.
But but for sure, um, they seem to be more educated. They're more curious. And so the ones that see us on social media and then call and make the appointment are almost always like they've been reading, they've been learning about the problem. They come in understanding their options, and it's kind of a pleasure to work with them because they've already educated themselves.
Yeah, I've heard that they're sometimes they come in, they're like, "Just sign me up, I'm ready."
Yeah.
Because they've learned so much through the ad, and then, with our team, we spend a lot of time with empathy, but we also you have a great website, you have resources that they're sent. And digital marketing leads, they are shopping, right? They're looking for options. So they come to you for that consult. Now that's your job now to close the deal, right? Let them know, one, are you a good candidate? Is this a good procedure? Will you see a good outcome?
Yeah.
What other questions do you have for me? Because if they walk out there and they're not sure they want to do this with you, they're going to move on down the road and look at the phone and see what's the next thing that's out there.
Yeah.
Um,
Yeah.
so
We actually had one. Um, we actually had one the other day that that came in. We did the workup. We scheduled the procedure. Then he called back and he said, I guess his wife was looking at our online reviews. He says, you really don't have too many reviews for prostate on your website. And I guess my office manager talked to him for a few minutes and they ended up canceling. He didn't, I guess he found somebody with more prostate
yeah,
embolization reviews on his website. But, so that's the double-edged sword, I guess. But that's
yeah,
all right. I mean, I'm not, uh, uh, maybe I'm not the best doctor for every single patient, but, there's plenty of patients out there.
I think you need to talk to Connor over at OBL Marketing about reviews. He's got some really good tips on how to get you those.
Yeah.
He'll say
I
this
mean,
to
we
you,
have a
like, come
lot of
on,
reviews.
Dr. Gropper, you know how to
Yeah.
do that.
Yeah. The problem is you know, we have a lot of we have more vein patients over the last 10 years than anything else. And so we get a lot of vein reviews. And that kind of, so if you start looking through our list of reviews, you're going to have to go through to see the prostates. But we
Yeah.
definitely need to be talking and asking more of the prostates and more of the hemorrhoids for reviews. One of the things we've noticed with hemorrhoids, which is kind of frustrating, is that, and it seems to be kind of unique to hemorrhoids, is the ones that get better don't even come back for their follow-ups. They just want to
Ghost.
forget about it and go live their life. And so, which kind of it kind of sucks for me because I don't get to talk to those people that much. I
Yeah.
get to hear the ones, the 15% that don't do great. Those are the ones I hear plenty from. But and and by the way, on for those patients, sometimes we'll repeat the procedure because the the hemodynamics down in that area are pretty complex and the blood flow can change. So after about 8 weeks, if somebody's still having symptoms, we'll sometimes reattempt the procedure and often have a better outcome. But yeah, for the hemorrhoids, they just as soon as they're better, they're gone.
They're out.
So
Well, and I would think asking for a review on a hemorrhoid, artery embolization, or even a prostate is very
yeah,
private, right?
yeah, they don't.
Unless you put it
I
out
mean,
there
I
on
wouldn't want.
Google that, like,
Yeah,
hey, Dr. Groper fixed my hemorrhoid problem.
I know.
Now, John Smith gave 4 stars, but I don't know. I mean, as a woman, if I had a Eufy procedure and it saved me and was life changing, I would want more people to know about that. So
Yeah,
I want to put a positive review out there or at least some sort of awareness. If any physicians are watching this and are either not doing digital marketing or even know who patient pro marketing is, can you just give a quick, what's your feedback? Would you recommend us? What you like?
yeah. I think you guys have been awesome. We well, I'd known you for a couple of years before we signed up. You were doing some other things, and then I saw you, I think, again at OEIS, and we talked, and um, I couldn't be happier. We started with you guys doing PAE promotion for us, and after about 2 months, we really started to see a significant increase in our consults directly from your efforts, and we track whether they're coming from you guys, coming from our um, our pay-per-click stuff, and so we can tell what's working. And so you guys have worked that, and then we just recently expanded to UFE with you guys, so we're excited to see how that goes. But yeah, 5 stars for sure.
Thank you. That's my Google review. I appreciate it. And your wife, Carrie, is awesome. Like she meets with our team weekly, provides
Yeah,
feedback, whether it's positive, negative, anything like that. You guys have been really awesome to work with. So thank you for that.
thanks. Yeah,
Um,
somebody's got to keep the office going because it's not me.
yeah. Well, usually the wife is the boss, so I get it.
Yeah.
In the home and the office. So before we leave and close out, where do you think embolization therapies are going in the next 5, 10 years? You had mentioned earlier, like, hey, in 8, 10 years, things could change anyways. Specific
Yeah.
embolizations, right? I feel like a lot of these, like hemorrhoids is still new. There's a lot of procedures that are still considered investigational. Like, where do you see this going in the next 5, 10 years?
Yeah, hard to know. I feel like prostate artery embolization is going to be pretty is going to hang on for a long time. I mean, I think things change so quickly these days in medicine, and there's new procedures coming out, but the whole premise behind PAE is really solid, and I just haven't seen anything that really competes with it yet. Um, I think I think hemorrhoid maybe the same. I think that especially with hemorrhoid, the relative lack of interest by GI to treat hemorrhoids, I think has definitely worked in favor of the hemorrhoid embolization. Um, ha Again, I don't see, from a strictly physiological standpoint, I don't see a real competitor to that procedure. I think embolization is definitely going very strongly into the musculoskeletal space. The embolizations for osteoarthritis of the knee, which we're doing for genicular artery embolization, it's called, as you know. We do that procedure, but insurance reimbursement is a big problem. I think that a lot of the insurers were paying for it, but they backed way off, which I think is a shame because it's another very solid procedure that in a niche where there aren't a lot of alternatives. Um, so that's going strong, and then people are talking about plantar fasciitis embolization. Plantar fasciitis can be a very difficult thing to treat, and plantar fasciitis embolization seems to be pretty effective. And then the latest one that I'm very interested in is osteoarthritis in the hand, especially for the first carpometacarpal joint,
Yeah.
um, which they're doing in Japan blind without fluoro. They just stick a needle into the radial artery and inject some embolant, which sounds frightening to me, but I need to go see how he does it
Oh.
because his results are pretty amazing. And I think over time they're probably going to find more uses for embolization in other joints
Mhm.
and for other disease
Shoulders,
processes.
elbows, hips.
Yeah.
We get asked about all those all the time. The thumb, we're gonna start hand away campaign soon too.
Yeah,
Um,
I think hip is potentially really interesting, but also we have to sort out some of the risks with that because hips are hips have their own issues with blood supply, and we certainly don't want to make things any worse. But um, but I think there's real potential there.
okay, so before we go, if somebody was watching this, whether it's a man with a large prostate or someone with hemorrhoids, and they just want to know if they might be a candidate, like what would you suggest would be their next step?
Well, I mean, certainly we have resources sources on our website that patients can go to and read about these problems, both the disease process themselves and the treatment options. We try to give like a very holistic summary of these problems without pushing patients in one direction or the other. I kind of just, that's my style. I just lay out the options and help the patient decide. I don't ever say you need this or you need that. But there's lots of online resources out there. Our website is vividvascular.com, but there's a lot of guys like me out there that are doing these procedures and very good at what they do. So in every state in the country, there's plenty of guys you can find.
Awesome. Well, Dr. Gropper, I really enjoy sitting here and talking to you. I think you're one of the coolest, chillest doctors that I work with. And you just said it right now, even when your approach with patients, you're not, aggressive and telling them what to do. You just lay it out there and sit back and say, hey, here's your choices, right? So
Yep.
so much for doing this with
Thank,
us and sharing, more information and bringing awareness to these sort of procedures. I really appreciate you being here.
thank you so much, Rachel. It was great talking to you.
You too. Thanks so
Talk
much.
to you soon. Bye.